Okay.
Okay.
So now it's recording. And now, okay, so you see my screen now, right?
I see your screen.
Okay, good. Okay, so let's start. So if you don't mind, I will introduce you and then we can start actually, yeah? We have
Okay, that's fine.
over 20 people now, so it's enough, and I think some more people will be joining later. So yeah, Michel, thank you for taking your time for being here today. I know you are in Texas in the STS meeting, so it's very nice you went back to the hotel to give this talk. And we are pleased and happy to have you here. I really like your paper, and we are happy to discuss it with you. But yeah, maybe if somebody doesn't know you, Michel is originally from Brazil and is a good friend of mine, but also one person I really admire. One of the example cardiac surgeons in Latin America, and he's now cardiac surgeon, and he's a clinical instructor in cardiac surgery in the Department of Cardiothoracic Surgery in the University of Pittsburgh, and also a aortic surgery fellow in the University of Pittsburgh Medical Center Heart and Vascular Institute. And you have a huge list of contributions to the cardiothoracic surgery literature. So we are more than happy and honored to have you here. And again, thank you for your time.
Yeah, happy to be here to give this presentation. Thank you very much to the Department of Cardiac Surgery at Leipzig Center. And I'm honored for the invitation. So, well, let's going to have a quick start with the presentation. So today I'm going to talk about this conundrum between TAVI versus SAVR in low-risk patients, and I'm going to show you data about the randomized controlled trials and real-world data. Next one. So these are my disclosures. I don't have any coins to declare, but I'm a cardiovascular surgeon, formerly trained in structural heart by means of a one-year fellowship that I did previously in Philadelphia, and I do both TAVR and SAVR equally. Next. So this is the paper that we published in the Journal of American Heart Association. We went to the American Heart Association meeting, presented there. We had lots of discussions there, and we analyzed the midterm survival of low-risk patients treated with TAVR versus SAVR. And we used a different technique that we usually, in comparison with the one that we usually do for meta-analysis, we were looking at the long-term, actually the midterm outcomes in this scenario. Next one. So why did we carry out this study? So there's another meta-analysis in the medical literature published in a top journal, in the European Heart Journal. And I got very curious about this paper when I read it. And it was also a comparison between TAVR versus SAVR, using basically the very same technique that we used for our own work. But they used some terminology that I found a little bit strange, like lower risk and higher risk patients. And when we classify these patients, we always look at them as low risk, intermediate risk, and high risk. And when I saw that word lower risk, I asked to myself, what does this mean, lower risk? I don't know what that means. And I started to read the paper, and this is what triggered us somehow to start to look at the data again. Could you please show the next one? So first things first, I think this is the main graph in that paper, showing all-cause mortality in lower risk trials. And again, this word lower risk, not low risk, showing no difference between patients treated with TAVR versus SAVR. And the authors concluded that in lower risk patients, there was an early mortality reduction with TAVI, but no differences after later follow-up. So the message here would be, well, we should go with TAVI for these patients because there is an early reduction of mortality and there is no problem in the future for those patients. Next one. But then I looked at the paper itself and said, okay, lower risk trials, what are these lower risk trials? So I saw that the trials that they brought together and they pulled was a PARTNER 3 trial, which is okay, an OCEAN trial, okay too, the Evolut low risk trial, okay too. But then I saw the SUR TAVI and the UK TAVI. And in my mind, these trials were not for low risk patients. This trials was for actually intermediate risk trials. And asked myself, okay, let me take a look at the trials themselves. And I reread these trials. Go to the next paper. So this is the UK TAVI, which was classifying that paper as a lower risk, but actually the authors clearly defined that the group that they studied was was patients with moderately increased operative risk, not low risk. Go to the next one. And then I saw also the TAVI, and right from the start in the title, you see these are intermediate risk patients. They're not low risk patients. There is a reason why we have the classification for patients low, intermediate, and high risk. So actually what the authors did was they merged the two groups, the low risk and the intermediate risk, and they called them lower risk trials. And I saw that right in the title of the paper published in European Heart Journal, say, well, I think this message is a little bit misleading. So next slide, please. So the other thing that really caught my attention was the fact that they concentrated on randomized control trials, which are supposed to be the top studies when it comes to medical science. But again, I want you to pay attention to this. When it comes to clinical trials, the clinical trials are actually not the end of the road. The post-market studies matter because what the clinical trials do is to show measurements and measures of efficacy, but not effectivity. So when we have all those devices and medical therapies tested in the world of trials, perfectly controlled, and they are brought to the market and they're used in real patients in everyday life, sometimes they behave in a different way. And this has been seen over the years in lots of medical theory. Imagine, for example, that the first statin that came to the market was not the simvastatin, was the serivastatin, which showed that you had a huge reduction of LDL, we had a huge reduction of cardiovascular events, but then after 2 or 3 years, dozens and dozens of patients dying from liver disease because this was induced by the medication. So the trials are not the end of the world. The post-market studies matter. The real-world data also matters. Again, I'm not saying that the real-world data and the real-world studies are superior to the trials, but they are the next phase for the trials, and surveillance is important. That study in the European Heart Journal did not take into account that. So we thought to ourselves, well, we should take a look at this better. So next slide, please. So we decided to take a look at the trials, including only the low-risk patients, the true low risk. We did not pull together the patients from the intermediate risk trials, but we also took a look at those studies that we consider high quality with real-world data, and we brought them together and we analyzed them together and separately to see what would happen. So this is the workflow that we use. We are very strict when it comes to the PRISMA statement. We comply with all the rules established by the PRISMA statement, and we always follow this strategy, the PICOS strategy, with the population patients with aortic stenosis. The intervention was TAVR, the comparison was SAVR. We looked at the outcomes, survival and all-cause death, as our colleagues who published that paper in the European Heart Journal, and we also differently, we did not include only randomized control trials. We looked at large registries, but only those who used some statistical method to improve the way that they look at their own data. And in this case, we picked the propensity score matched studies. So go to the next slide. So these were the best studies we found in the medical literature. On the side of the randomized control trials, truly low-risk populations. We had the PARTNER 3 trial, the NOTION trial, the EVOLUTE low-risk trial. In the propensity score matched studies with large registries in the world, we found the Avalon registry, the Observant registry, the FinValve from Finland, and the studies in Canada and also in Germany. So these are the 5 best real-world registries in the world. Go to the next one. So some characteristics of our overall population. We had a total of over 5,000 patients in the TAVR group, 2,600, in the SAVR group, 2,800. The mean age in all these studies were over 70 years, and the mean age ranging from 73 to 80 years. Female patients were very well represented in these studies. Most of these studies are going around 40-50% of female patients, and the transfemoral access was the most frequently used approach. Go to the next one. So this is the first thing that we found. So when we pulled it together, all the studies, randomized control trials, and high-quality real-world data, we found this difference between SAVR versus TAVR. So you see that in the beginning, you don't see much of a difference between surgery and TAVR. And after this time point of 2 years, the curves start to split. And over time, they split more. So you see that the overall survival in the TAVR after 8 years was 48% and 57% for SAVR. But you clearly have this, as you see that red arrow, you see a clear evidence of violation of the proportional hazards assumption. So when it comes to Kaplan-Meier curves and overall survival analysis, you have to keep in mind that this model is based on the assumption that the hazard ratio keeps being the same over time. And when this does not happen, the Cox models are not valid. So this is a clear violation of the proportional hazards assumption. And then we moved on to analyze more of this data. Could you please go to the next slide? Yeah, so as I was saying, so you see that when we see the behavior of the hazard ratio over time, you see that in the 0.0, everything favors TAVR. As the time goes by, the hazard ratio starts to go up, 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 crosses the line, the one line between 0.5 and 1.5, and goes all the way up over time. And then you see that the hazard ratio over time establishes that there is more risk for TAVR over time. Keep in mind that these are low-risk patients, okay? So this is the statistical proof that we had a violation of that assumption based on which the Cox models are, and we should not just look at the data like we looked at in the previous graph. So we moved on with our analysis. Go to the next slide. So this is what we call landmark analysis. So imagine that the first curve that we had there showing that the curves were splitting after 2 years. And we saw that there was a violation of the hazards assumption. So you have to break down that data and you have to analyze it again. So you see that from the time 0 all the way up to the time 2 years, at this time point, there's no difference between TAVR and SAVR. After 2 years, from that time point on, then you see a difference between TAVR versus SAVR, and SAVR seems to be better than TAVR. But again, keep in mind that we are pulling together all the studies, randomized control trials, and propensity score matched studies. Go to the next slide. So then we have to break down the data again. So you see that there is a clear difference in the behavior of the trials and the propensity score matched studies. So when we analyzed only the trials, we didn't see any difference. When we looked at the real world data, but this one is high quality data, at least what we should consider the highest quality of data in terms of real world data, you see this clear difference. So there's something happening between these two worlds. In the randomized control trials, we see this kind of result on the left, and on the right, you see completely different result. So we start to look after and to search for reasons for that. Go to the next slide. So this is another way of analyzing data when it comes to survival. So most of people are not that well familiarized with this, but this is called restricted mean survival time. So when we use Cox models, we are looking at risk, but we don't know how much time really there is in terms of survival for each group. So we have a mean time survival for one group, the mean survival time for the other group, and we see the difference. So you see that in the beginning, again, you see that survival favors TAVR, and over time, this difference does not remain. And after 4 years, we start to see a clear benefit in terms of survival for SAVR. But again, take a look at the data, and you see that the benefit in terms of difference between the mean survival time in the TAVR group and in the SAVR group is just 187 days. And clinically speaking, this is the benefit for SAVR over time. It's half a year. And we should ask ourselves if patients are willing to go through a surgical procedure to gain 6 months of life in the long run. And this is something that we should keep in mind also. Go to the next slide. So we ran also a meta-regression because every time that we see results in terms of overall populations, there are other covariates that have some influence on the results. So it's not just about TAVR versus SAVR. We always know that even for randomized control trials with the loss of follow-up, the groups start to be different. They're the same in the beginning, but they're different over time. And we look at some covariates that might have some influence on the final results, but we didn't find any influence in terms of age, female sex, diabetes, coronary disease, risk score, permanent pacemaker implantation, mismatch, PVL. We looked at lots of variables and lots of covariates, but we didn't find any difference specifically for this analysis. Go to the next one. So the main findings was the difference in overall survival between TAVR and SAVR may be minimal or absent in the short term, in the first 2 years, but may favor SAVR in the mid and long-term follow-up. However, the fact that the survival benefit for SAVR versus TAVR beyond the 2-year follow-up was observed only in the propensity score matched study, as we highlighted, and not in the randomized control trials. This precludes definitive conclusion regarding the superiority of SAVR for midterm survival either. As a surgeon, I'm not just open my mouth and say that SAVR is better than TAVR, because this is not what we saw when we looked at the data. Go to the next slide. So when I looked back and looked at the data again, despite the fact that we have randomized control trials were looked at as the perfect way of carrying out a study, and also the propensity score matches studies, which are seen as the best way of resolving some imbalances between the groups, I still found imbalances between the groups. So if you look at the propensity score match, and this is why I always tell people, be very careful about the propensity score matches studies, because you will highly likely find differences between the groups after the propensity score matching. So even for the Avalon registry, you're going to see that the SAVR group had more severe aortic regurgitation. It was not just about stenosis. They had almost a double of aortic regurgitation. In the study by Villalta, the SAVR group had much more coronary disease, although this was not statistically significant, but it really caught my attention. In the FIN valve registry, the SAVR group had much more planned PCI or CABG surgery. So you see that in the TAVR group, you had only 2% of other procedures in terms of coronary disease, but in the SAVR group, you had like 8 times more procedures. So these patients were sicker. And in the Scheffer study, we also saw that the TAVR group had much more patients with New York Heart Association class 3 and 4. And these are problems from that you can see at the propensity score matches studies. But the randomized control trials also had problems. They did not protect from biases other than non-random allocation, the pivotal studies exploring that. And then I would like to show a couple of slides with graphs that I extracted from the study by Barilli. So this graph is very interesting to show that even in randomized control trials, patients are supposed to receive a certain treatment, but there is what we call, it's a problem in the randomized control trials called deviation from assigned treatment. And you see that the TAVI group had much less deviation from the assigned treatment when we compared that with the SAVR group. And this is a problem in the randomized control trials. Go to the next slide. This is another problem, which is a selective pattern characterized by a lower risk of dropouts in the follow-up. So it's interesting to see that the group of most interest, which was the TAVI group, when compared with the SAVR group, they had much fewer dropouts at the follow-up than the surgical group. And this is a selective pattern in the studies. Go to the next slide. So the other problem in the trials is that we had patients in the SAVR group receiving much more additional treatments in comparison with the TAVR group. And this is a sign that these patients were selected on the basis of the STS risk score. They were classified as low-risk patients, but somehow they ended up having much more additional treatments in comparison with the TAVR group. So we ask ourselves where the equipoise is. Is there really equipoise? We're not that sure. So as you can see, the very same way that we have problems in the propensity score matched studies, we also have problems in the randomized control trials. So go to the next slide. Mateo?
Yeah. This is
the next slide.
This is the
Oh,
next.
it was repeated. So go to the next. Go to the next one. Sorry.
Yep.
And there are some factors at play that frequently, these factors are frequently ignored and not taken seriously. Permanent pacemaker implantation, paravalvular leak, prosthesis patient mismatch. Go to the next slide. So when I looked at, so our study was focused on the long-term, the midterm results actually. Couldn't say long-term because we don't have yet 10-year follow-up at least. But if you look at the studies in the beginning, right after the procedures, you're going to see that the TAVR groups, they end up having much more pacemakers, much more mismatch. In the SAVR group, mismatch is a problem that is much more frequent in the SAVR group, while pacemakers are much more frequent in the TAVR group, and PVL are much more frequent in the TAVR group. And these factors, they play a role over time. And people tend to think, oh no, pacemakers are not that important. A mild PVL is not important. Is that really true? Go to the next slide. So first things first, this is a study that we published recently in JSky, and we were comparing the survival and rates of rehospitalization patients who received the TAVR, comparing those who needed a pacemaker and those who didn't. And we saw much more mortality and much more heart failure-induced rehospitalization those who received the pacemakers. So pacemakers are not a minor thing when it comes to TAVR. Go to the next slide. So Moderate and severe PVL and TAVR outcomes, same thing. When we looked at overall survival, freedom from hospitalization, freedom from cardiovascular mortality, patients with moderate and severe PVL, they die much more when they receive TAVR. And go to the next slide. And we tend to think that mild PVL is nothing, but it is something. If you look at patients who left the hybrid OR with mild PVL and they received a TAVR, they have worse overall survival, they have much more rehospitalization over time, and they have more cardiovascular mortality. So even mild PVL is not just a minor thing. Although we tend to think that, oh, it's just a mild PVL, but a mild PVL is not a minor problem. It becomes something for patients. Go to the next slide. Mismatch is a problem that we see much more frequently in the SAVR group. And this is a study that we published in the European Journal of Cardiothoracic Surgery showing that mismatch is a problem right from the start in the perioperative period. After 1 year, after 5 years, 10 years, patients with moderate and severe PPM, they have much more trouble over time in terms of mortality. Go to the next slide. And there is a myth out there establishing that, oh no, mismatch is not a problem for TAVRs. Well, what I can tell you is that patients have much less mismatch with TAVR. But once mismatch is there, even in TAVR, it's a killer. Patients have much poorer overall survival, much higher rates of mortality when they have some mismatch. So we have, yes, it's true, we have less mismatch with TAVR, but when we have mismatch with TAVR, it's a killer as it is with SAVR. Go to the next slide. So thank you very much for the opportunity to deliver this presentation, and I hope that we can discuss it and have some good contributions in the way that we look at patients who receive TAVR and SAVR. I think TAVR is a great thing. I really love doing them. It's very, yeah, I think this is something that all surgeons should learn how to do that, at least those who are more interested in valve surgery and valve diseases. But I think that what happens, we just had a presentation by Jad Malas from the City of Sinai, and he showed that TAVR being used very frequently now in patients younger than 60 years old, and he presented the results with STS database, and the survival after 5 years of patients considered low risk, younger than 60 years old, it's a tragedy, and this is already happening all over, at least here in the United States. And we really should think about it, if we really should be using TAVR so widespread the way that we have been doing. But again, TAVR is something really good, and we should improve the technology, we should improve the techniques, surgeons should be more and more familiarized with it, and work along with our colleagues in interventional cardiology, but I think that we should be more rational when it comes to the using of TAVR technologies. Thank you very much.
Okay, Michel, great. Thank you for your talk. It was very interesting, and you actually did a very good, let's say, summary and overview of the whole topic, not only your paper. I have a few questions, but maybe somebody else wants to start. I can always, of course, start, but I forgot that detail that you mentioned about the survival benefit of SAVR of more or less half a year in the long run.
Yeah.
But I was wondering, how was the median follow-up of these studies together, all the PSM and RCTs together? You know the median follow-up?
It's 4.7 years. It's the median follow-up.
So it's 6.
That's why I always tell people, be very careful about the terminology long-term. People think that more than 5 years is long-term. It's not. It should be more than 10 years, at least the latest time point. And the median follow-up should also be coming, it should come near 10 years. But when you have a follow-up of 8 years and you have a median follow-up of 4.7, the best you can call it, it's a midterm.
Okay, so that means you have, let's say you win 6 years, 6 months of life if you get SAVR in 5 years of follow-up. So that might mean that maybe after 10 or 15 years, it might be even higher, because you showed how the proportional hazards assumptions was actually not valid and the lines crossed. So it might increase over time.
Yeah, we would need much more follow-up. That's the point. We have to wait for the follow-up of the studies to be published. And then those who work with meta-analysis are always like that. We have to be on the lookout for the new publications, the longer follow-ups. Very soon, we're going to present at the ATS the trial sequential analysis with longer follow-up and analyzing the data in a different way, different from what I just showed it to you. There are other ways of looking at the trials. There's a different type of meta-analysis called trial sequential analysis. And you see how much the trials really came near the benefit, because this is something that we should even put to patients. When you're talking about risk, oh, the risk is 40% higher. If I'm honest, patients don't care about, oh, my risk is 40% higher. How much I really gain from this, or how much I really lose. So if you think that, okay, remember that these patients, the mean age was around like 7 years old. They're always over 7 years, and they were between 70 and 80 years old. These people, they die. They die. It's not just about the strategy that you use to treat them. They die because life ends one day. But imagine that we have been pushing more and more for lower risk and patients with long life expectancy. If we are already observing this in people who do not have a long life expectancy, the low risk trials, the youngest patients were 73 years old. Keep that in mind. You are 73 years old. What is your life expectancy at this age in Brazil, in Latin America, in Germany, in the United States? Okay? That's your life expectancy. What if I run the very same trials with people who are now 60 years old? These people have a very long life expectancy, right? And this makes a difference too in the way that you're going to analyze the data. But the moment that you use this data and you want to translate that into patients who are younger, it's a little bit hard if you look at your patient and say, look, the true benefit you're going to have with SAVR is just 6 months if I follow up on you for 8 years. And imagine that SAVR, you're going to have to recover from your procedure. And this is not nothing for your patients. You're going to have, imagine that you're a young patient, you're going to have to stop to work for a while. You're going to have to stop working for a while, right? And you're going to have to recover from the procedure. And everything that you're going to gain is statistically, which can be different in real life, it's just 6 months. We have to think about it. But remember, our population is an old population. It's not a young population. So yeah, it's true. This difference, this benefit could be much larger, but we don't know that. And every time that people start to do trials, for example, the Germans now are going to start the dedicated trial. And the range of age that they're going to get is 65 and 85. I just do not understand why they got such a large range, because if I have lots of patients here between 75 and 85, but I put everybody together on the same age bracket, and I'm going to translate the results of patients between 75 and 85 to those who are between 65 and 75. And again, people keep telling, but this is not about age. No, this is not about age. Age is nothing. Life expectancy is everything. Do you understand? When we talk about, oh, these patients are between 65 and 75, it's not about their age, it's about the amount of life expectancy that they have. Do you understand that?
Yeah, I wanted to ask you, how do you guys estimate life expectancy in your heart team? Because that's very difficult to measure and to calculate somehow.
Yeah. So in my previous institution and also in my current institution, all these patients are evaluated, for example, for frailty. So for example, frailty is really something that throws a patient to a high risk or moderate or low risk. Imagine that sometimes you have the STS score saying that a patient is very low risk. And then you use, for example, the KCCQ, and you use frailty scores, and these patients are frail. These patients are not just low risk. And we have lots of studies showing now that frailty increases the risk, and also shows it's kind of a surrogate way of measuring life expectancy. Frail patients, they live shorter. So we don't have any. Sometimes we just, being very honest, you eyeball on the patient. If you see a 75-year-old patient who's super healthy, walking, doing everything, living his life, if some even practicing sports, these patients tend to have a longer life expectancy. And you see a patient, as I see here, for example, 70 years old, and these patients are destroyed by life. You look at them and you say, okay, this patient here, diabetes, smokers, very obese, What is the likelihood of this patient living another 10 years when you were seeing this patient this moment? Do you know what I mean? So it's a combination of scores, KCCQ, frailty score, and also clinical judgment. You look at the patient, you feel your patient. This is more or less how, I do, and I see everybody here doing this.
Okay, there are two questions in the chat. I will read the first one.
Yeah.
From Timur Kayashev, sorry if I don't pronounce it correctly. Hello, thank you for the fantastic presentation. Are there specific anatomical considerations or patient characteristics that may influence the choice between TAVI and SAVR for low-risk individuals?
For sure. So in terms of anatomical considerations, I'm going to give you a simple example. LVOT calcification. If you see a patient who is low risk with a huge LVOT calcification, you're going to deploy a TAVR and you have no control as to how that device will behave in the LVOT. So I remember various patients who could have received TAVR, was a 76-year-old patient, low risk, very healthy, but the patient didn't want to receive surgery. And you look at the imaging, and the pre-planning is very important at this moment. Learn how to do the pre-planning, okay? And you look at the LVOT, and the LVOT has a huge chunk of calcium with protrusion. These patients are no good to receive TAVR. I'm not saying that you cannot do it. I'm saying that the risk, for example, of annular rupture is much higher. So most of these patients, for example, we avoid. You have a patient with low-risk patient, could go for a TAVR, and then the calcium score is 10,000. I can assure you, you're going to put a TAVR there, it's going to be a mess. You're going to have strokes, you're going to have annular rupture. The TAVR, the device will not be very well deployed. It can embolize. The device can also not expand properly, and you're going to have a bad outcome. So patients with a very, very, very high calcium score, I wouldn't have a number to give you because this is not very well established. But patients with a too high calcium score, 11th, I recently had a patient like this. The calcium score was 11,000. That's a stone. You can't put a TAVR there. You have to remove those leaf flats so that you can have a new valve there. So LVOT calcification, super high score. Patients with a very small aortic annulus too. So if you look at the patient is a low risk patient, and you are able to do safely aortic annulus enlargement, you have small aortic annulus, you shouldn't go with balloon expandable valves because the effective orifice area is much smaller. So most of the times we would go with self-expanding valves with supraannular conformation. So, but if the patient has a very small aortic annulus and you look at down the road and the patient's, you feel like this patient's going to live longer, maybe the first procedure you should have is a SAVR with aortic root enlargement. You give a bigger valve, and down the road in 10 years when the patients come back, then they can receive a valve and valve without mismatch. So aortic annulus is also the size of the aortic annulus and the predicted effective orifice area. You can calculate that. You're going to look at the annulus. The annulus is too small for that. You're not going to be able to give a valve with a good effective orifice area. You're going to end up with high gradients. Why would you go with TAVR? You can do that. I'm not saying that you can't. You can do that with supraannular valves. But if this patient can tolerate surgery and you can safely do an aortic root enlargement, go for the aortic root enlargement, give a bigger valve. When the patient comes back down the road after 10 years, you can give a valve and valve safely. So there are lots of anatomical aspects that you should consider. Nowadays, problems with the femoral arteries are not much of a problem anymore because we know now how to do it with transcarotid access, transaxillary. You have other ways to do that, but when you don't have ways to treat these patients through the transfemoral access, then you should go for surgery if you don't have other via. Now we already have also the transcaval via, but sometimes some groups only work with transfemoral access and they don't domain other access, so surgery would be also an option because we know for sure that these patients can tolerate well surgery. So, and one thing that we should keep in mind is that we should never exchange a low-risk SAVR for a high-risk TAVR. Meaning, you have a patient who is considered clinically low risk for both procedures, okay? And then that patient is trouble for TAVR for whatever reasons. LVOT calcification, protrusion in LVOT, very small aortic annulus, problems with access. etc., etc. And your TAVR, although this patient is considered low risk because the STS risk score is low, you know that the procedure itself is going to be a high risk. Why should you go for a high risk TAVR when you can offer a low risk SAVR? Do you understand what I mean?
Yeah, yeah.
So this is
Perfect.
another aspect that we factor in.
Okay, so there are two more questions in the chat.
Yeah.
So from Ibrahim, thanks a lot for the great presentation. How was the rate of combined procedures in the SAVR arm in the propensity match studies compared to the RCTs? And how was the percentage of patients with aortic regurgitation in the SAVR arm against the in the SAVR arm in the RCTs versus the PSM studies?
So yeah, we didn't have much difference in terms of aortic insufficiency. In one study, I listed there during my presentation. One of the studies you have, I think it's the Avalon registry. The Avalon registry in the randomized control trials, this was not of a problem. Both arms had the same rates of aortic regurgitation, but for the propensity score matched studies, in one of the studies, which was the Avalon registry published in JTCVS, besides the aortic stenosis, the patients had much more aortic regurgitation than the TAVR group. So this is a difference that is there. I already listed in the presentation, and people can see the differences because the propensity score matching, according to the variables that were chosen by the groups, when I looked at the studies between the lines, you can see that there are still important differences in the groups. And this is why I always tell people, look, the propensity score matching studies, they're great to work with real world data and to mitigate the effects of the groups, but they're never perfect. You go for them, you look at the data, and also how many variables. When I see propensity score matching studies with only 5 variables, what is the likelihood that you really had some sort of equipoise between the groups? The likelihood is very low. I really like those studies with 30 variables, propensity score match with 30 variables. Then you could at least mitigate a lot in terms of differences, you know. But yes, there are in the randomized control trials, we didn't have a problem in terms of aortic insufficiency, but in one of the studies, the Avalon registry, we had more aortic regurgitation in one of the groups.
Okay. So the other question in the chat is if SAVR is used in patients less than 65 years, are mechanical valves still being used in the US? Do you know about this?
Yes, a lot, but this depends on the culture of the institution. I'm going to tell you this. I've been in 2 different institutions. Okay, in my first institution, Lung Canal Heart Institute, when I was there, I didn't see many mechanical valves for young patients. They were almost always going for bioprosthetic valves. Okay, I don't remember seeing lots of mechanical valves. Here at UPMC, Heart and Vascular Institute, the University of Pittsburgh, the culture here is different. Younger patients, younger than 65, they always offer the option of mechanical valve as the first option. So there is a matter of local culture in the institution. So in my new institution, University of Pittsburgh, we offer mostly mechanical valves for patients, and if they can deal with monthly INR, have access to Coumadin, etc., we feel like we talk to the patient. We always offer the option for patients with mechanical valves. So here's much difference, and here they have great results. We very recently we published a couple of papers comparing mechanical and bioprosthetic valves, even for patients who had, for example, aortic root replacements here. We do a lot of bento procedures here. And when we compare the results of bento procedures over time with mechanical valves versus bioprosthetic valves, regardless of aneurysmal dissections, the patients with mechanical valves, they fare much better than those with bioprosthetic valves. But keep in mind that this is also dependent on the fact that patients can deal with the situation of receiving a mechanical valve. In Brazil, I come from Brazil, I was primarily trained there. I can tell in the public health system, it's almost impossible for you to offer a lot of mechanical valves. Why? Because my patients in Brazil, they have a hard time to have access to monthly INR. And despite the fact that Coumadin is not that expensive, they also have trouble to have access to the Coumadin. And most importantly, it's not easy for them to be followed upon by a primary physician there. So in my country, in the center where I was trained at the University of Pernambuco, in the northeast region of Brazil, which is one of the most underdeveloped regions in my country, mechanical valves are rarely an option because there are some social issues involved in receiving a mechanical valve. Here in the United States, most places patients under 65 years old, they would go for a mechanical valve. Yeah.
Okay. So are there any questions?
I have a question. Hi, Michel. It's good to see you again.
Antonia, nice to see you again.
Hi. Good to see you. Thank you for the great presentation. I'm going to ask the obvious question. What do you think about the Ross Renaissance in that context of mechanical bioprosthetic valves and then also resource limiting factors as you described in Brazil?
Yeah. So I think the Ross procedure, first things first. What do I think? I think nothing, actually, because I'm not experienced in this to say much. What I can tell you is two things. You talk to older people who have been around for a while, and I had a conversation with Dr. Scott Goldman, who was one of my mentors when I was at Lung Canal Heart Institute in Philadelphia. Dr. Goldman has been a surgeon for like 40 years, and he told me that he saw the Ross procedure coming back like 3 times in waves over time. So he told me that, oh, Michel, people start to do the Ross, they do a lot of Ross procedures, you're going to have much better overall survival, et cetera, et cetera, et cetera. But then they start to have the problems and people have to have reoperations done. It's much higher risk. And then they stop doing Ross. And then after 10 years, they come back. So Dr. Goldman told me that he saw 3 times the Ross procedure having this coming back to the arena. And if you talk to other older surgeons, they're going to tell you the very same story, okay?
That's a very interesting point.
Personally, I want to learn the Ross procedure. I think it's a great tool to have. In Latin America, if I were to do Ross procedures in my region, for example, my idea would be to do the Ross procedure, but I wouldn't have a homograph to put in the pulmonary position.
Mm-hmm.
I would have to get a Dacron graft, a bioprosthetic valve, and suture there and put in the RVOT. This is the option that I had there if I decide to go for the Ross procedure. If I ever come back to Brazil, which I think will happen someday, what does the data show? And this, you can find it published in January, Trends of Cardiovascular Medicine. I can share the paper with you guys. I can send to Matteo. Matteo can send it to you. If you compare the results of Ross procedure versus mechanical valves, bioprosthetic valve, there is no way of bioprosthetic valves having any benefit in comparison with the Ross procedure, okay? But when it comes to mechanical valves, it's very clear. 20-year follow-up, propensity score matched studies. Remember, we still don't have yet randomized control trials for that. What the study shows is, I have almost more than 1,000 patients in each arm, all the studies propensity score matched. And what you see is that the Ross procedure comes with much better survival in 20 years, but much more reoperations in 20 years. And then 2 questions. The patient has to survive the Ross procedure to benefit from it. It's the first thing. And it's not like we have any surgeon in every corner able to do Ross procedures. I think the 2 types of surgeons who are the mostly, how can I say, who would be able to do that safely because of their own backgrounds are congenital heart surgeons and the aortic root surgeons. These are the 2 types of surgeons who I think could do safely a Ross procedure. But the mechanical valves have something to offer. We have to talk to our patients. Some patients will clearly say, yeah, I'm not going to live as long as I would live with the Ross procedure, but I don't want you poking around my chest every 10 years or every 5 years. Do you know what I mean? And if you ever saw a redo Ross, I can tell you it's not a redo AVR. It's much, much harder. So I'm not sure. People keep telling about the Ross procedure, but I think that the Ross procedure is going to end up being something practiced in centers of excellence or something along the lines. When it comes to medicine, if it's not something affordable for everybody, I'm not just talking about money, I'm talking about also access. If it's not affordable, is it medicine really? So I come from Latin America. My background's completely different. It's very hard down there to do cardiac surgery. Mm-hmm. High-level cardiac surgery, complex procedures. It's not easy. Imagine, we're talking about TAVRs here. Our government has just approved the TAVR for the public health system. When I was a resident, never saw a TAVR. I was still doing an AVRs as a resident in 80-year-olds. We didn't have TAVR in the public health system. It has just been adopted. So you see how much Latin America fell behind on these technologies? So it depends also on where you are. Who are your patients?
Thanks for your answer. Thank you.
Yeah, you're welcome.
Michel, I have one last question. Coming back to the topic TAVR in low-risk patients. So if we decide to adopt this strategy of TAVR in low-risk patients, do you think everybody should be doing it, or only like high-volume centers with a huge experience and with the, let's say, availability of heart surgery? Because there are some
Yeah,
people
I'm all about, look, if you look at the data, I'm pretty sure that pretty much everything, not everything, there are some studies saying the contrary. This goes also, it's the same for congenital surgery, it's the same for aortic surgery. There's a clear difference in terms of quality of outcomes when it comes to volumes, and there are some numbers well defined for that. These numbers are not that well defined yet, but it's very clear that, well, we're all, in terms of TAVR and SAVR, we're all proceduralists, we're operators. We're both interventional cardiologists and surgeons. We're proceduralists. And we know for sure, and I'm not even sure that we need a trial to prove that. The more we do, the better we get at doing that. And I think that this is the best way for patients. So do I think we should have referral centers for TAVR? Yes, I think so. I think we shouldn't have everybody doing that, because the experience would be diluted across the centers, and then the outcomes would get poorer for sure. But then we have to start to think about access, because when you have only these procedures in referral centers, sometimes patients cannot just travel 500 kilometers, 700 kilometers to have access to your treatment. So I'm going to give an example. I come from the northeast region of Brazil. I lived in the state of Pernambuco, and cardiac surgery was basically practiced in the capital. The capital is on the extreme east side of the state. If you are in the state of Pernambuco and you need a TAVR or SAVR, you're going to have to travel to that city, okay? More than half of the population in that state lives on the west side of the state. They have to travel 500, 600 kilometers to have access to TAVR, and they don't even have the money to do so. So we end up creating an imbalance of the healthcare that we can provide for those patients. In terms of outcomes, if you look only at the quality of outcomes, I have no doubt that we should have referral centers. All the TAVRs procedures being concentrated in some centers with few people doing it, and then you would guarantee the quality of outcomes, because the volumes bring experience, and experience brings quality. And as surgeons and interventional cardiologists and proceduralists in general, we know that the more we do, the better we get. So yes, I think we should have referral centers, but keeping in mind that we shouldn't create disparities in terms of health care that we can provide. So we always have to look at where we are. It's different. We both come from Latin America. I'm now in the United States. You are in Germany, and you know how different these systems are, and how different our people are. You know. Yeah.
Okay, Michel. Well, if there are no any additional questions, I think that's it for today. Or somebody else wants to ask something? Okay, well, I think there was a lot of discussion. I have, by the way, I forgot, I have to apologize my department's head, Professor Borger, because he had another appointment and he couldn't join the meeting.
No problem.
He sends you his best regards. And again, thank you for being here. Thank you for taking time. And yeah, enjoy the meeting. Enjoy the STS.
Thank you very much. Greetings from the United States. Take care.
Bye-bye.
Bye-bye.